Welcome back to AMCPreplab. Last time was the topic of bronchiolitis, and today let's get into pertussis. Alright, so pertussis is caused by the bacteria called Bordetella pertussis and occasionally Bordetella pyropertussis. The infection is spread by respiratory droplets. Children less than or equal to 6 months are more prone to having complications such as apnea, bradycardia, severe pneumonia, seizures, and encephalopathy. It can occur in children who have taken the vaccine, but the advantage of taking vaccine is that the illness is less severe. Neither vaccination nor natural disease confers complete or lifelong immunity to the patient. The incubation period of pertussis is 4 to 21 days, and it's usually around 7 to 10 days. The infectious period though can get quite confusing. It's basically from the onset of symptoms to whichever is earliest. It could be till 21 days after the onset of symptoms, or 14 days after the onset of paroxysmal cough, or completion of 5 days of appropriate antibiotics.
Take your medicine, son.
The clinical features is basically divided into 3.
There's 3, actually.
The catarrhal phase, the paroxysmal phase, and the convalescent phase. The catarrhal phase is present for 1 to 2 weeks, and the symptoms for this are coryza and non-productive cough. The meaning of coryza is that there is inflammation of the nasal mucosa. The paroxysmal phase is also for 1 to 2 weeks, which presents as episodes of paroxysmal cough, which peak about after a week. The term paroxysm means that there is a sudden burst of a particular thing, and in this case it is cough. It is classically with an inspiratory whoop and a post-tussive vomiting. This is what the patient's cough actually sounds like. The convalescent phase is present for 2 to 6 weeks and may last for up to 3 months, and the cough tapers off slowly. There can be superimposed viral infection, and that can cause a recurrence of this paroxysmal cough. In this phase, the cough is not specific and persistent, and there can also be poor feeding, weight loss, sleep disturbances, and also the other members of the family are frequently affected and have a cough. Now coming on to the examination, with all the cough and the clinical features mentioned above, one might expect there to be a lot of examination findings, but usually fever is uncommon and clinical features usually absent. Complications, on the other hand, might feel a bit tricky, but once you know why it occurs, it can be quite easy to remember. The infection can travel to the ear, and that causes otitis media, and if it reaches the lungs, it can cause pneumonia. The other complications are seizures, hypoxic encephalopathy if it reaches the brain, and pulmonary hypertension secondary to pneumonia. The cough can be so severe that it causes rib fractures, pneumothorax, scleral hemorrhages, and hernias. Investigations are usually not needed since it's a clinical diagnosis, but in a few cases, nasopharyngeal swab for PCR is the investigation of choice, and it's more sensitive than culture. The PCR is usually negative after 21 days or 5 to 7 days after treatment with antibiotics is commenced. Culture of nasopharyngeal swab or aspirate is the most specific. Culture is recommended for catarrhal phase, early paroxysmal phase, severe cases requiring admission, suspected treatment failure, or if it's requested by the public health unit. Pertussis serology is not very helpful in this condition. Chest X-ray is only indicated in unwell infants less than 6 months old because, as mentioned earlier, there is a risk of developing pneumonia with pulmonary hypertension. Treatment is indicated if the diagnosis is in catarrhal or early paroxysmal phase, if the cough is present for less than 14 days or if the symptoms for less than 21 days. This may actually reduce the spread as well as the school exclusion period. If the child is requiring hospital admission or if there are severe symptoms or complications mentioned above.
Just need to take your medicine.
Have a big sleep and not worry.
The antibiotic of choice in pertussis is either azithromycin or clarithromycin. The dose is not particularly important for the exam, but it's good to know. The dose will vary depending on the age. If less than 6 months, it is 10 mg per kg oral daily for 5 days. If the child is more than 6 months, it is 10 mg per kg with a max of 500 mg oral daily on day 1, then 5 milligrams per kg, max of 250 mg daily on days 2 to 5. Now on to the clarithromycin dose. If the child is more than or equal to 1 month old, it is 7.5 mg per kg, max of 500 mg oral, twice daily for 7 days. If macrolides are contraindicated, give trimethoprim sulfametrazole. The dose would be 0.5 ml per kg, max of 20 ml for 7 days. Do not give erythromycin due to the risk of developing pyloric stenosis. Consider admission for all infants less than 6 months given the risk of rapid deterioration. If there is respiratory distress present, if the child is unable to feed, if there is evidence of pneumonia, if there is cyanosis or apnea with or without coughing, and if seizures are present. Now on to the exclusion criteria or the isolation criteria. This bit can get confusing, especially when you're reading all the diseases together. So write it down somewhere with the disease name and the exclusion criteria and it'll be good to go. So we have to exclude from school, childcare or contact with others outside home until the earliest of 21 days after the onset of symptoms, 14 days after the onset of paroxysmal cough, or completion of 5 days of appropriate antibiotics. So these three are when the child is most infective, as we've seen earlier. So after the period of infectivity, exclusion criteria is not anymore needed. Unimmunized children are those who have not taken any doses of the vaccine, whereas incompletely immunized are those children who have taken less than 3 doses. These children, if less than 7 years of age, must be excluded from school or childcare for 14 days from the last exposure to infection or until they have taken 5 days of appropriate antibiotics. Pertussis is a notifiable disease and has to be notified without fail to the authorities. Now, management of contacts. The antibiotic regimen is the same as for the treatment of cases. Prophylactic treatment is aimed at preventing spread to infants less than 6 months. Now, I'm going to give you a list of people who have to be treated within 14 days of their first contact with an infectious case or within 21 days for infants less than 6 months. The list is as follows: any exposed infants less than 6 months of age regardless of setting, any exposed pregnant woman in the last month of pregnancy regardless of setting, contact of a pertussis case who may transmit to an infant less than 6 months of age. These include all household members where the infant is 6 months of age present, healthcare staff who work with infants less than 6 months of age or with pregnant women, example in the maternity ward or newborn nursery, all children and staff in a child care that care for infants less than 6 months of age. The 6 months of age keeps repeating because they are more prone to developing complications and a more severe disease. So we have to be very careful with them. Unimmunized or partially immunized children diagnosed with pertussis should still complete the pertussis immunization as per schedule. Close contacts who are not up to date with their immunization should be given DTPA as soon as possible after exposure. Adult contacts who have not had pertussis containing vaccine in the last 10 years should be offered one. Consider consultation with a local pediatric team when the infant is less than 6 months of age, as they are more prone to developing complications and a more severe disease. Child has a severe disease with complications such as apnea, cyanosis, pneumonia, seizures or encephalopathy. Consider transfer when the child has a severe disease with complications requiring care above the comfort level of the local hospital. Consider discharge when tolerating coughing episodes without becoming hypoxic and or bradycardic. Most infants who are admitted with pertussis continue to have coughing paroxysms, and if the child is able to tolerate adequate fluid intake, we can consider discharge. To sum up important points, pertussis is a notifiable disease Antibiotics reduce the severity and risk of transmission if given within 14 days of paroxysmal cough or 21 days of symptoms. Children are no longer infectious 21 days after the disease onset or 5 days post antibiotics. If the child is less than 6 months, he has a greater risk of severe disease and complications. Alright, so that's pretty much it for pertussis. If you have any questions, leave them in the comments and I'll get back to you. Like, comment and subscribe. Do let me know what topics you need in the future videos. Okay, alright, see you next week. Bye.